Hey guys, welcome to PT Snacks Podcast. This is Kasey, your host. And if you're tuning in for the very first time, what you need to know is that this podcast is for physical therapists and physical therapist students who are looking to grow your fundamentals in bite-sized segments of time. Now, today we're going to be covering the PCL, or Posterior Cruciate Ligament. And I can't believe that I haven't covered this before, but we're going to cover it today. So we're going to cover exactly what it is, how this gets torn, and what do we do about it. Before we do that, if you are enjoying this show, it's been helpful to you, you've used it on your clinical rotations, if you wouldn't mind supporting the show in one of three ways, that would mean a lot to me. The first one is just if you know somebody who you think would benefit from this show, tell them about it. The second one is to just leave a review wherever you actually listen to this podcast. That really just helps the show to grow. And then the third one, if you feel led to give financially, that just helps to support some of the fees that go into making this podcast actually a thing, because it is a one-woman show. That's appreciated, but do what you can, and then anything is appreciated, right? So with that being said, let's dive right into what is a posterior cruciate ligament. Okay, so what is the PCL? So essentially, the PCL is one of our largest and strongest intra-articular knee ligaments that helps as a primary posterior stabilizer. So it helps to prevent tibial posterior translation. It's made up of two main functional bundles. We have our anterolateral, or AL bundle, and we have our posterior medial, or PM bundle. The AL bundle, or anterolateral, is going to be larger and more vertical. It's more dominant in mid-flexion for posterior tibial restraint, whereas our posterior medial bundle is smaller, a little bit more oblique, more key in extension and deep flexion. So they work together essentially to help stabilize the knee. It works with the anterior posterior meniscofemoral ligaments that form up to 4 synergistic fiber bundles that help to resist posterior and rotary loads, because we like to do some twisting and stuff like that in sports, right? So the function, as I mentioned before, the PCL is a primary restraint in posterior tibial translation, especially at higher flexion angles. It's also a secondary restraint to varus and valgus forces and external rotation. Chronic high-grade deficiency can increase contact pressures and accelerate medial and patellofemoral degeneration. So something to consider if someone has torn this ligament. What are their treatment options moving forward? How does this happen? PCLs can account for 17 to 20% of knee ligament injuries, often in young adults. So when I say young adults, I mean 20 to 35 years old. The most common mechanisms will be like a dashboard injury, where there's an anterior force to the proximal tibia and the knee is flexed. So like sitting in a car and they get hit by a dashboard in a motor vehicle accident. That's the classic cause. There are other ways that you can do this, because not everybody who tears their PCL has a dashboard injury. It could also be sports trauma. Someone could fall on a flexed knee with a plantar flexed ankle. Collisions in soccer, rugby, football, skiing, things that involve you running into things with your knee. A hyperextension or hyperflexion event can cause proximal tears, and anterior tibia plateau compression fractures can also do that too. And excessive varus or valgus or rotation often means there's a combined PCL and posterior lateral corner or other capsuligamentous injury that's involved. So some things to keep in mind. That's why it's important to understand the purpose of the PCL, so that you know that if something failed in its purpose, what is the thing that failed that I should screen out for? Now, in terms of symptoms, this could be acute. There's going to be pain, swelling, and hemoarthrosis. Their pain can also often be patellofemoral, anteromedial, or posterior pain. Isolated tears, they may feel some instability, could be subtle feelings of giving way, or more typical in chronic and combined injuries. Depending on how bad the injury is, sometimes it's a matter of you might get some false positives for a lot of tests. So you're trying to control for the most severe thing and then assess as you go. So in terms of trying to figure out, does someone in front of you have a PCL injury? Their history is going to be important, such as did they have some sort of dashboard injury or fall or hyperflexion? that happened? Was it a high energy or sport-like activity? How long has it been since their injury happened, and what are the functional demands that they're trying to get back to doing? Common tests that are used for PTs would be like a posterior jaw test. This is found to be pretty highly sensitive and specific for PCL injury. So essentially, the posterior jaw is where you're seeing if there's an excessive posterior translation of the tibia on the femur. There's also posterior sag sign and a quadriceps active test, pretty similar to the posterior jaw test. And then varus and valgus and dial tests to screen for PCL and MCL involvement. MRIs are going to be pretty much the gold standard for confirming if there's a PCL there or not. And they can also identify if there's concurrent meniscal, chondral, or other ligamentous injuries. Stress radiographs can help to quantify if there's any posterior tibial translation, graded injury. They can predict PLC involvement, as well as just ruling out some other things. So there are different grades of injury that can be applied to the PCL. Grades 1 through 2 are going to be more partial or moderate. There's not as much posterior translation, whereas like a grade 3, we're talking about a complete rupture with marked posterior translation. Now, depending on where you are in the country, what country you're in, will determine what's the norm standard practice for what happens to these patients on certain, depending on how severe the injury is. But some lower grade injuries, they may be managed non-operatively when patient demands are pretty low to moderate, meaning they don't need to go out and play rugby and compete. They're not at a competitor level. They just need to maybe stand and do the dishes every once in a while. For surgical considerations, that's going to be for people who have larger demands on their activities or things that they want to get back to doing. If they have multi-ligament injuries, high-grade laxity, concurrent injuries like meniscal tears, things like that, that they're already going in for, they might just go ahead and do the PCL. And again, depending on where you are in the country and who you work with, generally the theme of progression, whether someone's being treated non-operatively or post-operatively, is in the beginning you're trying to kind of protect the knee and create a healing environment by reducing excessive demands that are too much of a stress on the knee and on the joint for what they are ready for, and then slowly build their way back up to it. So in the beginning, there's more of a protective period where you're trying to avoid things that cause excessive posterior translation. Maybe they're put in a brace to help manage that. Maybe their weight-bearing precautions are adjusted to keep them successful. Maybe they have crutches, etc. And then you're trying to help improve their pain-free range of motion without a posterior sag. They may progress to more quad-focused strengthening, trying to avoid things, again, that kind of replicate that posterior jaw in terms of your exercises. You may also throw in hip strengthening, hamstring strengthening, proprioceptive neuromuscular training, and then eventually working towards more return to sport. But essentially, in the beginning, you're trying to protect the graft from a lot of posterior shear. So they might not be doing a lot of early hamstring loading or high flexion, open chain knee flexion. You're watching for posterior sagging in their range of motion when you're looking at flexion. And the progressive quadriceps, again, depending on what all they've got going on, they might be looking at whatever other injuries. If there are concurrent injuries that are going on, you're going to treat it by the most conservative needs that are there, whether it's the PCL or another tissue that was disrupted, essentially. Again, this episode's not really necessarily about specific treatment. I want you to understand more of why the protocol that you have from a surgeon might be in place, because we need to consider more of what the healing timeline is of the tissue that's aggravated, so it's a ligament, and help to protect that tissue until it is ready for more stress to then help it to then adapt and be able to handle more and more stress down the road. If we apply stress too early, we are at risk of doing more harm than good. if we don't apply enough stress, we are at risk for not preparing them to get back to the activity that they need to do. So it's really about understanding what the needs of the tissue are, or tissues if there's multiple injuries that are going on, and understanding what its job is so that you can offload it from its job while it's healing and then ask more of it when it is ready to accept load. We are not going by social media standards or what this pro athlete could do. We're going by what the body biologically is ready to do. Okay? So I would challenge you with this to, if you have a protocol or you can find one online, go through that and try and explain to yourself, understanding the job of the PCL, why certain things come at different aspects of the protocol, and and then understanding how are you going to test to make sure that they're ready for the next place in the protocol. Because we don't want to just blindly follow the protocol. We need to test the patient that is in front of us to make sure that they show that they have gotten the foundations that they need from each stage before they move on to the next one. We want to set up our patients for success. That was longer than I meant to spend on that portion, but I hope that is helpful to you. So what you should have gotten from today is understanding what the PCL is, what its job is, how does it get injured, how do we assess it. And then I would say my homework for you would be able to take a look at your protocol and understand why are you treating it in that way based on what you know about the setup, how it was injured, how it was, what its job was, etc. If you have any questions, feel free to reach out at ptsnackspodcast@gmail.com. You can also find me on YouTube, Instagram, TikTok, probably too many places, or you can join the newsletter. And every week I try, and with every episode, I try and send out an update on what the episode's about. You can just reply to me on that one too, as well. But other than that, I hope you have a great rest of your day. And until next time.